Hello, my name is Stephen Goldstein, and we're going to be introducing head and neck pain, a clinical approach to treatment including facet joint strain and intraoral application. Well, one of the things we want to look at is through head and neck pain is what are some of the causes of head and neck pain. And through this DVD, we're going to focus primarily on myofascial components and joint components. I'm not going to be as heavy with the muscular components. I'm going to make some assumptions that you are fairly skilled in that respect. Head and neck pain and face pain really has multiple origins. The injuries can be numerous and plentiful, and so you have to definitely do a differential diagnosis. Some of the causes for head and neck pain is cervical instability, degenerative joint disorder. You're going to go ahead and have whiplash and acceleration injuries. You're going to have TMJ disorders. You're going to have headaches, and the headaches can be from a number of causes. Cervical instability is another cause. So these are reasons that you're going to be dealing with the head and neck, and often the myofascial and articular components are a culprit in that. So we're going to go ahead and actually look at some of the reasons that a muscle area has a dysfunction, and we're going to talk about what we call cervical muscle strain. Now, many cervical muscles don't terminate in tendons, but really attach directly to the periosteum. Muscles respond to injury, really, when they're contracting and recruiting surrounding muscles to help protect. And so that really is a splinting mechanism that does cause muscular spasm. The strains really are more akin to collagen disorder than any tendinosis or tendinitis. Myofascial pain syndrome, which is thought to be a resultant clinical picture, is very, very important, but it actually is often a secondary response to the facet joint. So that's why I thought having you look at facet joint strain is really important. And in fact, the facet joint is the most commonly source of referred pain in complaints that are dominant with headache, almost to 60%. Your cervical and your C5 and C6 region is also one in which it refers very dominantly into the shoulder area. And so this is what you want to look for, and your C2 and C3 areas are going to go ahead and bring that headache pain up. The facet joints really are quite responsible for a substantial portion of chronic neck pain, and really having a look at assessment, which really becomes technique, can be really important for you. Typically the joint pain will be unilateral. It can be dull, aching neck pain. And so you want to look at that. Those will all be symptoms for you with that as well. What are some of the causes? We really have talked about that. So what I want to talk to you more about is maybe the findings. Some of the findings you're going to find will be palpatorily. There's going to be bogginess, edema. There'll be ropiness, fibrous components to the back of the neck. Your myofascial pain or referral upon palpation could be dominant. These are things that will be indicative that the muscles are really at play. And when you go ahead and do your active range of motion, you often will see a change. The limited range of motion will change again because once the spasm is reduced, you're going to get an active change. So that's the stuff we're going to work with. The other thing I want to mention is just how you organize your approach. You're going to see how I organize it from a global to local back to a global approach, but we're also going to be thinking about lines of fascial tension, and we're also going to be initiating a parasympathetic response. So you'll see that in play here too. The nervous system still is a really strong factor in my work. So that's some of the ways that you can go ahead and organize your work. The last thing to think about then is the selection of techniques that you're going to put into play. Different authors do different ways. I'm going to show you mine. Nervous system will be first. Myofascial release will be second. We're going to move global and then move local. You're going to see some fascinating things like change to hamstring length from just doing some very short resistive work at the suboccipitals. We then could bring in indirect techniques for positional release. That's a great way to play. And then finally we're going to use some contractive, which we're going to do for the joint, but you certainly can use for the muscles. I'm going to assume you have a little bit more knowledge, and certainly other authors have done greater detail on tapes. So I hope you're going to enjoy the ride. It's a pleasure for me to show you these techniques, and I hope they're really useful.